what it comes, especially to my office in Italy, are mainly stricture created after an endo-urological procedure such as QRP, URS, but also for other reasons, for example, cystoscopy or other endoscopic procedure. So these type of stricture generally represent the most common causes and the etiology for stricture in my country. We know that the urethral stricture has a prevalence of roughly 300 patients over 100,000. So it's not a rare disease. It tends to be a rising problem, especially because of the diffusion of different endoscopic procedures to treat BPH and benign prostatic enlargement. So since we have abandoned techniques that are, for example, suprapubic simple prostatectomy, and we start to do minimally invasive surgery for BPH, there comes the problem of urethral stricture, because most of the procedure, especially if they are misconducted or because maybe the patient has a particularly higher sensibility to instrumentation, the incidence of stricture started to increase with the diffusion of endoscopic procedure. Many new techniques have evolved for BPH, for example, the resume, aquablation, laser technique, green laser. So all these options have increased the number of surgery that have been done from an endourethral and endoscopically, and that had increased the rate of stricture as well. So usually we have to distinguish between a patient that has been referred to me because of urethral stricture problem and a patient that comes to the first urologic evaluation. I see very, very few cases of primary urethral stricture. What I see most are stricture that have been treated elsewhere and failed. But basically, if you question the story of the patient and you ask them how the story has started and evolved, those that developed the stricture after endoscopic surgery, they said that the surgery for the prostate went wrong. They had problems in the postoperative procedure. The surgeon told us that the procedure was technically difficult. And when they removed the catheter, supposing that they will be able to void in well after the BPH surgery, after a weeks or days, the flow started to decrease. Most of them went in urinary retention. They had to put a catheter again. The catheterization was difficult, and any other following attempt to remove the catheter failed. So then started diagnostic procedure with cystoscopy, voiding or retrograde urethrography, and the urologist finds the stricture. So most of them also attempt at first treatment endoscopically, mostly. Uretrectomy, DVIU, was the most common procedure that endo-urology attempts in the first place with patients with stricture after BPH surgery. Now they have learned how to use, for example, Optilum, dilatation through catheter balloon. So I see many patients also, they comes to me that they have already done this dilatation with the paclitaxel coated balloon. But after even this second failure, then they get referred to me to analyze the situation and solve the problem. When I see a patient that maybe have a stricture, not because an endoscopic BPH procedure, and because maybe the stricture is idiopathic, it started to develop slowly, not related to instrumentation or catheterization. The story of this patient is like they've not been able to void and pass urine well for their entire life. They sometimes have a long story report where, especially when they compare to other men, to other colleagues or friends, they always reported difficulties in voiding. Their flow was weaker as compared to men of similar age, and that they had suffered of recurrent UTI, prostatitis, but they maybe never investigate the reason why. Until they found the symptoms going worse, and the UTI coming with a higher frequency, and so they decided to start some urinary investigation and test. But what it happened when they referred to the first urologist, the first subject of the interest is the prostate, not the urethra. So they are categorized as prostatic patients with prostatitis, BPH. So half of them goes in an attempt to do BPH surgery. And so the BPH surgery just simply get worse, the stricture. Some other, they start with the investigation, they find the stricture, and then if the urologist is competent and it feels that he can treat the stricture, maybe they undergo endoscopic procedure, or they start referring the patient to reconstructive urology, for example, to my office. So this is the typical history of the two most common urethral stricture patients.